Right, should we get going?
Yep.
Dan, you happy to get going?
Yes. Okay.
Great. Okay. Okay, I'll meet you now, Dan. Hello and welcome to the Call for Applications webinar for the Commonwealth Partnerships and Antimicrobial Stewardship. Can I ask that everyone is on as we get going? I would also try to mute you from here. I can press mute all. There we go. Right, thank you. So you should be able to see our screen. The recording of this session along with the slides will be available on Monday, and this will go on our website on www.set.org and on our YouTube channel. We will have time for questions throughout, and I do invite you to type questions as we speak so that we can quickly scroll through these during the Q&A. There should be a question box to the right of your screen where you can input your queries. So my name is Richard Scone-James. I'm Senior Grants Manager here at Tropical Health and Education Trust. I'm joined today by Will Townsend, also from TET, and Dr. Diane from the Commonwealth Pharmacists Association. Hayley Wickens will also be joining us from CPA to run through a couple of slides. And Chloe Tuck from the CPA is also on the call to take any further questions. So just to quickly run through the agenda, this really is an overview of the Commonwealth Partnerships for Antimicrobial Stewardship call for applications. Hopefully most of you will have had a chance to read through the call documents, and this is a chance for us to just pick through some of the detail and also for you to ask us further questions. So my colleague Will run through that overview and the eligibility and application process. Diane will speak through the specific approach to AMS that we'd like to take in this programme, and Hayley will touch on a case study of a project that she delivered in the Caribbean. And then I will go into the principles of project planning with some basic advice for putting together an application form, and we'll touch on the behaviour change element of the programme. We'll then just outline the next steps for applicants. As I say, throughout we'll pause for questions as we go. If I could ask you to write your name and email address in the chat box so we have your contact details available, that would be really helpful. So if you could start doing that now as we get going, that would be great. So without further ado, I'll pass on to my colleague Will.
Yes, thanks Richard, and welcome everybody to the webinar. Just a quick explanation of my slides. As Richard said, I'll be giving an overview of the scheme, its aims, some of the timeframes involved, and eligibility and things of that nature. So, as Richard said, the grants programme is called the Commonwealth Partnerships for Antimicrobial Stewardship Scheme, and it aims to leverage the expertise, particularly in pharmacy, of UK health institutions, volunteers and technical experts to strengthen the capacity of the national health workforce and institutions in 4 Commonwealth countries to address antimicrobial resistance challenges, particularly in the area of antimicrobial stewardship. And those 4 countries are Ghana, Tanzania, Uganda and Zambia. Now, the scheme is funded by the UK Department of Health and Social Care's Fleming Fund, which is a £265 million government commitment of official development assistance to support countries in collecting high-quality data relevant to antimicrobial resistance that can then be shared and used nationally and globally. And by supporting the collection of this antimicrobial resistance surveillance data and other relevant data, we'll be collectively better able to understand the scale and scope of the problem of antimicrobial resistance and therefore be better placed to tackle it. And if you'd like any more information on the Fleming Fund and its other investments and how it takes a One Health approach, the website is on the slide there. And the slides will also be available online following this webinar. So the Fleming Fund has 7 objectives, which are in this slide. And this scheme is going to tackle 3 of them. 1, developing and supporting the implementation of protocols and guidance for antimicrobial resistance, surveillance and antimicrobial use. 2, collating and analysing data on the sale and use of antimicrobial medicines. And 3, advocating for the application of data to promote the rational use of antimicrobials. Now, the scheme will be delivered in partnership by the Tropical Health and Education Trust in partnership with the Commonwealth Pharmacists Association. And in case anybody doesn't know of either of these organisations, FET is an international NGO that supports the training of healthcare workers in low middle income countries to address the shortage of trained health workers overseas. And since 2011, we have partnered with over 130 NHS trusts, royal colleges and academic institutions. And in 2017, we supported the training of over 22,000 health workers. We do a lot of things at FET, but of most interest to this particular scheme, we are managing agents for 3 grant streams. 1, the Department for International Development funded Health Partnership Scheme. 2, the Johnson & Johnson funded Africa Grants Programme. And 3, the Department of Health and Social Care's Fleming funded Commonwealth Partnerships for Antimicrobial Stewardship Scheme. And the Commonwealth Pharmacists Association, on the other hand, is a UK-based charity that advances health, promotes well-being and improves medicines-related education and use for the benefit of the Commonwealth. By supporting the development of safe and effective systems of medicines management, maximising the skill level and encouraging the better utilisation of the pharmacy workforce, the Commonwealth Pharmacists Association seeks to encourage the optimisation of medicines and health-related advice given to the public with the aim of improving health outcomes and reducing health inequalities throughout the Commonwealth. So the aims I've spoken about with regards to this programme will be achieved using health partnerships. And these can be defined as partnerships between UK health institutions and their peers in low and middle income countries, where UK health workers volunteer their time to co-develop strategies and share skills and knowledge to address priority locally defined health system issues, which in this case will relate to antimicrobial stewardship. It's important to note that this model is a mutually beneficial model and for the health workforce and institutions in both the UK and overseas countries. So health partnerships, they often begin through an informal or personal connection between individuals in 2 institutions, and it's then the process of widening this connection, deciding to work on a project together and understanding the need to formalise and institutionalise the relationship that marks the beginning of a health partnership. And health partnerships seek to address priority gaps and needs identified by the low and middle income country partners and usually focus their activities on a series of projects which often support human resources for health development through the training and education of healthcare workers overseas. And then activities, especially when the partnership has been established over a number of years, can then broaden and scale up their activities and also include activities to strengthen aspects of a health system, such as clinical pathways and policies. And then just to note that under the scheme, there is funding available for both established and new health partnerships. And I'll go into a bit of detail later on in the presentation about how we're defining these. So yes, under the scheme, there's a total of £600,000 available for up to 12 partnerships, and there are 2 tiers of funding available. Category A is for the new partnerships, and they can apply for funding in the range of £10,000 to £30,000, And category B is for established partnerships, and they can apply for funding in the range of £30,000 to £75,000. And it's important to note that there's no specific amount of funding allocated for either category within that pot of 600,000. This will be decided during the selection process. So grants allocated under the scheme will target themes and areas of investment not currently being developed by other Fleming Fund projects. But they will make an important contribution to the overall success of the fund, and it's aimed to see an increase in the rational use of antibiotics and ultimately a reduction in morbidity and mortality associated with antimicrobial resistance. So as such, the call has three themes. 1, antimicrobial stewardship, including surveillance. 2, antimicrobial pharmacy expertise and capacity. And 3, infection prevention control. As you can see from the slide there, it is a requirement of this call for all partnerships to include plans to address points 1 and 2. It's not a requirement to address infection prevention control. However, if it's appropriate to do so within the scope of your project and partnership, then we obviously encourage this. So through the scheme, we expect to see the following outcomes. 1, institutions and workforce demonstrate improved knowledge and practice related to antimicrobial stewardship prescribing practice and infection prevention control. 2, evidence of effective antimicrobial resistance interventions with standardized tools and guidance being used by local institutions and/or national partners. And 3, NHS staff demonstrate improved leadership skills and a better understanding of the global context of antimicrobial resistance in their work. And if you'd like to see examples of the type of thing you can look to achieve from project activities in order to meet these aims, then please do refer to the Q&A document, which is available online through our website. So there are respective roles of THET and CPA throughout this programme. However, given it's a partnership, these aren't completely delineated. There's going to be overlap and input throughout the duration of the project. Nevertheless, THET will oversee the application and grant giving process, including the negotiation of contracts and drawing up of monitoring, evaluation and learning plans, and also project plans. And during project implementation, THET will also provide support for project planning, resolving project management challenges, and management of the reporting and monitoring, evaluation and learning process. And will also oversee things relating to finances as well. And we'll also provide support through learning events, publications, and then online resources, of which we have a number already online. And we'll seek to signpost people to what we think is most relevant after the webinar. But also please do feel free to ask us any questions about specific resources that you have in mind. And then CPA will provide targeted technical assistance to health partnerships to ensure that they're in line with the expected outcomes of the scheme. And this will include provision of a suite of options to support baseline assessments, technical preparation of health partnerships, and partnerships activities in country as well. And then in the lead up to the deadline for applications, both organisations can provide a matchmaking service of sorts. So THET will publish the existing partnerships in the 4 countries on our website in case you'd like to try and get in touch with any of them. And then CPA are also happy to connect to people in the 4 countries, people and organisations, sorry, that are interested in engaging in this scheme. And there's an email address in their slides that you can pick out, but again, we'll include that in the FAQ. So on to timeframes. So the grant call went live last week on the 31st of October, and the deadline for applications is midnight on the 4th of January 2019. Just to note that applicants should complete their grant application form, their budget template and letters of support collaboratively and submit to the email address ams@thet.org. And applications received after this date and that's the 4th of January, just to repeat that, will not be considered. And yes, partnerships will then last 15 months, starting in February 2019 and ending in April 2020. Please note, though, that we don't expect project activities to necessarily start on the 1st of February. There'll be approximately a month of discussions to finalise monitoring, evaluation and project plans, and then also to hold inception workshops to prepare partnerships for the scheme. So in terms of the application and selection process, there will be an initial check by THET for eligibility and quality, and then shortlisted applications will then be reviewed by a selection panel consisting of technical experts and staff from THET and CPA. And just to note that some of those technical experts will come from our expert advisory group for this scheme. And then selection will be based on an assessment of the grant application and budget in the areas detailed in section 5 of the grant overview. And applications that best meet the criteria and requirements will then be awarded. And obviously, THET's decision to award grants will be final. After award of funding, there'll then be a consultative process of project development to draw up appropriate monitoring, evaluation and learning and project plans. And there'll also be an inception workshop covering a number of topics. But just to give an example, current initiatives and good practice in relation to antimicrobial stewardship in low and middle income countries, best practice and theory in relation to behaviour change interventions, and existing guidance and protocols and how these have been or could be adapted in different contexts. This is expected to take place in February, and successful applicants must be willing and able to engage in this process. So, on core requirements of country eligibility, applications for the larger funding range of £30,000 to £75,000 must be made by established health partnerships between a UK health institution and an overseas health institution. And the same goes for newer partnerships. And the grants must be for single time-bound projects that are deliverable within the budget and time frame proposed and agreed with THET. Projects must operate within Ghana, Tanzania, Uganda or Zambia, and letters of support from each partner institution must be submitted along with the application. And then projects must also operate in one or more low and middle income country health institution. So how we're defining established and new health partnerships. We define an established health partnership as one that's been working together for over 6 months, one that is formalised and institutionalised, and one that can clearly demonstrate adherence to THET's principles of partnership. And then we define a new partnership as one that's either been working together for less than 6 months or has not yet started working together but has intentions to do so. It doesn't need to demonstrate adherence to all of THET's principles of partnerships, but must demonstrate a commitment to do so. And it needs a clear strategy of how the partnership will become formalised and institutionalised. So in terms of institutional eligibility, in order to be eligible, the lead institutions must be formally recognised as a health education institution, regulatory organisation, professional association, or NHS if in the UK, or public/not-for-profit if overseas hospital. Academic institutions or professional associations can act as the official lead for a grant, but there must be clear joint leadership from an NHS hospital, and it should be clear that some members of deployed staff have a clinical/pharmaceutical role. NGOs aren't eligible to apply for this grant stream. However, we do acknowledge that some health partnerships have a charitable arm to support fundraising activities, and these charitable entities are eligible to have a role as managing agent for the grant. But applicants must be able to show that the project will be delivered by the eligible UK and low and middle income country health institution and not the NGO. NGOs are also not eligible as overseas partner institutions unless they're an overseas not-for-profit clinic or hospital. And then, yes, the lead UK partner and not an NGO will also be responsible for signing the grant contract and overall delivery and reporting for the project. So the scheme it's built upon the contribution of NHS volunteer time, and those involved in the project, and in particular those carrying out the training, should ideally be volunteering their time. However, we will allow staff costs for project management and monitoring and evaluation. The scheme will fund projects then in which the ultimate goal is to strengthen the capacity of the local in-country health workforce and institutions to address antimicrobial resistance challenges. If the core requirements and country eligibility are met, applications will then be judged throughout the application process against the project, partnership and scoping study criteria, and these are detailed in both the grant overview and Q&A documents. Now, these are the project requirements. I'm not going to go into each one, but the project requirements are criteria that the project you want funding for must meet. And these are the partnership requirements, and again, I won't go into each one. And the partnership requirements are criteria that the partnerships themselves must meet. And then there are the scoping requirements, and these were defined through a scoping study led by CPA, which Diane will talk about in her slides. And these are more specific to antimicrobial stewardship and antimicrobial resistance themed issues. Just to note that those applying for the larger sum of money must, where applicable, demonstrate how they aim to meet all of the points of the scoping study. And then new partnerships applying for the smaller amount should include some of these, but must consider what is feasible within the resources available. So thank you everybody for listening. That's the end of my slides. The email address on there is the email address where you should submit your applications, and also if you want to have any follow-up questions, then please send to there. I think we can now take any questions.
Yeah, so we have a couple of questions already. Thank you for sending those through. First one from Ammo for George, which is about, are we allowed to partner with the Ministry of Health's agency or department? I think in principle that could be fine. We allow for regulatory bodies to be involved. I would suggest though that you just email that address just to give us a bit more clarity on who it would be and who the other partners in the application would be, so that we can give you guidance straight away on that.
Also, Diane here, also to highlight that obviously the hospital element. So yes, they can be part, but really important that hospitals are involved on either side. Yes, definitely. And then the second question was to ask about who should the letters of support be from. So we're asking for any partner institution that is listed on the application form, that they each provide a letter of support. So it's not just from the two lead partners from the UK and the overseas institution. It's any key partner that is listed in the application form. And finally, a question from Rachel. Can a partner in the UK be an educational organisation providing education to NHS professionals? I mean, maybe I've got a similar response to Mo for George, Rachel. I think we'll discuss after you sent that question about the partner eligibility, and we do need the NHS Hospital Trust to be one of the key partners in the application form. But as we said, other organisations can come in as part of the process. So maybe it's best just to give us an email just to clarify that again. And yes, just back to the letters of support. We've had a few questions about who exactly needs to sign up. So this can come from any part of senior management within the institution. Ideally, someone who does have who will have a connection with the actual project. And then a question from James is, can we have a list of UK partners? Yeah, so thank you, James. We are going to publish a list of partnerships from the 4 countries within the scheme and the UK. That will go up on our website later today. So we encourage you to, for those who aren't in a partnership already, to look through that list and then send us an email to ams@thet.org saying which partnership you might like to link into, and then we can talk to that partnership, see if they would also be interested, and link you two up. And in addition to that TEP is putting up through the scoping process, we've also identified hospitals in the various countries, in the 4 countries,
who may be ready or at a stage where they may be willing to partner with UK hospitals. So CPA will also at the same time try and pull together the list, because I think what TETH is putting forward is the current partnerships that are ongoing, that it will be a good opportunity to actually expand their remit.
Yeah. All right, great. That's all the questions we've had so far, but please do keep typing those into the chat box. And now over to Diane.
Thank you. And just to encourage those who joined recently or haven't done so yet, to please put your email address and your names within the chat box. We do that because it means that we can then email you the slides and also future information about the project. Okay, thank you, Richard and Will. So in this session, I'm going to really focus around what the technical aspects of the program. I'll talk you through. I'm hoping I'm controlling this. Okay, so talk you through the objectives, focus around the stewardship elements, highlighting some of how you consider the situation in context. A case study, so we'll present a case study which Hayley will take over from me to just briefly share her experience of working in the Caribbean around stewardship in a similar funded project, but funded by the CDC in America. And then what technical support you can expect and why you should hopefully get involved. So going to the objectives very quickly. So Will in his presentation highlighted the importance of antimicrobial stewardship, but also within that is, we cannot divorce infection prevention and control from stewardship when we're trying to tackle antimicrobial resistance. But as I go through how we did the scoping, hopefully you'll understand why we've had a more of a focus around the stewardship and use measurement compared to IPC. It's around having decision-making tools available as well. And again, this is quite key here, is that we're not asking for new guidelines to be developed. Actually, we are discouraging that. What we are asking is around implementation of what is already available. The WHO has several guidelines already that these countries should be implementing or are already implementing, but need further support or tools to implement them further. Also, part of the key objective for this program is that NHS staff are also able to demonstrate benefits back to the NHS for themselves, but also as to the NHS as a whole. As we know, antimicrobial resistance affects us all. It's really important that we get involved in the global context and we support the global context, because travel, as we know, it's what happens all the time. People go from the UK to other countries, and many people come into the UK. So actually we have a role together in a global context to support tackling antimicrobial resistance, and stewardship is a core element within that. So it is really around partnerships, strengthening the workforce. So there's a key focus around strengthening workforce capacity, training of workforce, particularly around antimicrobial prescribing practice. How do they use their microbiology data to inform decisions, infection prevention and control as well, and then particularly around surveillance of antimicrobial use, which is what we have found through the scoping has a major gap. So I've highlighted it again, partnerships implementing protocols to inform good practice, those developed by WHO. And also, there are also other international consensus documents that you could consider implementing. So an example is a recent consensus around antimicrobial stewardship programs, which has involved infection experts from across the globe, some of them from these countries that we are hoping to work in. So again, it's really around implementing rather than developing new things. So then going on to how we got to what is in the scoping what's in the core document around the scoping elements. So we carried out a desk-based scoping approach, and that was extraction and selection of information and resources and literature review. So we did the usual literature review. We also went through grey literature, but Mutt MacDonald, which are part of the Fleming Fund as well, supporting building capacity for laboratory, they had already completed some scoping for these countries as well. So we used some of the information from their reports. We also used information from the WHO websites, and so the assessment of countries' implementation of their national action plans. Alongside that, we had interviews with members of national pharmacy associations in the 4 countries, again, really to get information of what is going on the ground there as a starting point. But we were doing this at a macro level, at a national level. And some of the, one of the key ones that sticks out, that always stays in my mind now, is around the essential medicines list, which is the WHO essential medicines list. So yes, all these countries have implemented the essentials medicines list in one way or the other. And there is a minimum stock control that hospital trusts must hold. And because of this, they ration how much antibiotics they give to the patients from the hospital trust. And some ask them that patients seek to get the remaining antibiotics of stock from elsewhere. So from their families, for example, could buy it from local pharmacies. So that was an interesting finding for us that we would not have necessarily picked up through literature. So it just highlights the importance of you having conversations with those partners in those countries to really find out not only what the issues are. So we knew that, there could have been a gap around implementing of guidelines. We knew that the essential medicines list was one option, which was updated to include antimicrobial stewardship and antibiotics specifically. But what we may not have been easily find out through literature was this whole challenge they have around stock and how they having to ration what they give out. We also had input from the expert advisory group members, and majority of them who have international experience. And we had input from the chief medical officer and the chief pharmaceutical officer. From that, we have created a scoping summary, which brings together all the information that we found in a summary format, and that it was from the gaps identified through the scoping summary that's what has informed what you have in the table and in the recommendations of what is a requirement or a suggestion. We also have country-specific documents, which really just pulls together information about those specific countries. And alongside that, we are working through putting together an accompanying resources toolkit of the various information we found. But bearing in mind that the information that we have is very much at a national level or a regional level, and there is this importance of you also considering the local level where you will be working. So from the scoping, the gaps that was highlighted was that there's a need to build systems for surveillance on antimicrobial use, and also the need to have tools to support stewardship, including clinical decision-making for appropriate use and training. What we found through our scoping is that actually there have been several similar partnership projects on infection prevention and control. Some of them funded through TET, but also some of them funded through US aid, some of them funded through the WASH program or included in the WASH program, and some also funded through from CDC. So there have been several projects around, and also patient safety has been another way that infection prevention and control has been tackled through partnerships as well. And so what was an obvious gap was that there hasn't been actually a formal partnership in this way from the UK that we're aware of from our scoping around stewardship. There have been pharmacy projects that have included some stewardship elements within them, but not a core focus around antimicrobial stewardship and tackling antimicrobial resistance. Within your approach to your projects, it's important to consider what the resource limitations are. So considering what the stock availability, so I talked about, the medicines and needing to ration, for example, considering what guidelines are available. So another finding for us was that we found that actually the 4 countries have a national infection prevention and control guideline, which is being implemented. So but what guidelines do they have around prescribing in general for clinical guidelines or clinical prescribing, or what guidelines do they have? Do they have any specific to infection, management of infections, and also what facilities are actually available, or what facilities do they have in the country, on the site that you're going to, and what tools do they already have? Something to be aware of, though, is not for us to have a preconceived idea of what is available, because actually innovation has been quite key in majority of these countries. So one of another finding through our discussions was that there may no internet access on site within the hospitals, but actually the clinicians have a mobile phone, and they often use the apps. Quite a lot to access information. There's just a little bit of a formatting issue. I don't know if others can see that as well. But this next diagram was just showing the importance to consider behavioral barriers. So the stock is considering the capability, the capability, the motivation and opportunity, and considering that actually just because somebody's capable does not mean that they're motivated to change. And sometimes do they have the opportunity? And that there is a COM-B framework, which links to the behavior change wheel, which you will see when the slides are sent to you by PDF, which combining capability, motivation and opportunity influences behavior. And when you know this, so hopefully you can see on the screen, what I can see is that in the green circle is capability. And within the capability section, actually some of the activities you can take to try and influence that could be around environmental factors, or do you need to develop new guidelines, for example, or do you need to train to increase the capability? But there are other methods that will need to be used if you wanted to influence motivation. And Rich, and actually something to highlight here is that there will be support around behavior change methodology and behavioral insights through another organization, which Richard will go into detail in his section. It's important to consider the workforce distribution and capacity. So we've talked quite a bit around pharmacists, but actually in many of these countries, there are more pharmacy technicians than there are pharmacists. So it's considering what actions, in addition to working with pharmacists, what training can be given or provided for pharmacy technicians or assistants, in a similar way for also medics as well as nurses. So just considering and understanding what the workforce distribution and capacity is in the organization that you will be working with. I talked about the importance of e-health. This is an example of an app that is used that is quite popular, which is called Hello Nurse. And so, as I mentioned, apps are and e-health is used significantly in these countries. So how could that support you? We're not suggesting that new apps are developed necessarily, but actually how can you signpost to and implement or help them implement the use of some of these? It's important to build on what's out there already rather than creating something new. So here I talked about there are IPC and WASH initiatives already. There are several antimicrobial guidelines as the essential medicines list, or actually how can you provide tools to support the implementation of these. And also, if you're providing any training, WHO has published this year competencies for healthcare workers around antimicrobial resistance. So it's going to be key to use that your training is either mapped to that framework, or that you use the framework to inform what training is provided. Thank you. That's a bit clearer now. And then in terms of how to approach the partnership, it's important to consider the national environment. So what is in the national action plan for the country that the hospital that you're working with is in? What are they trying to? Is that tech colleagues?
Let me mute.
So what? What are three attempts to implement from action plan? And how can that be implemented, or how can you support the local environment to implement this? And one of the ways that we are considering these projects are that potentially they could be seen as pilots by the governments of these countries around implementing their action plans. And we talk a lot about considering projects that can be scaled up and sustained. And again, it's important to also consider the healthcare workers. So do the healthcare workers have motivation to act on antimicrobial resistance? Do they perceive that it's important? So you may want to assess this beforehand, and CPA will certainly provide some tools for those that are awarded the grants. Do they have managerial support or workplace culture? So it's really important to consider what the managerial support is, and I think that's going to be quite key, especially around sustaining and especially around scalability. Are there other building blocks of the health system, such as leadership? Are they sufficiently developed, or are there other issues that you need to consider? Can I have the next slide, please? Thank you. And in terms of checklists for the partnership approach, it's important to consider the multidisciplinary team. So although we have given a lot of examples around pharmacy, and we've said that pharmacy is quite key to this, and pharmacists are quite key to the project in developing the projects on both sides, so both in the UK and in the country that you'll be working with, pharmacy is a key core element. But it needs to be also multidisciplinary team. So it's a multidisciplinary team that includes pharmacy. As I mentioned already, importance to consider the national action plan for the country. Incorporating infection prevention and control is really important, but find out what has already been done in those countries and consider how you take it to the next step, rather than starting from the beginning again or duplicating efforts. Considering the low resource restraints that there are, and I mentioned already, e-health, there have been several e-health initiatives that have had a good uptake. So, for example, the Hello Nurse that I showed earlier, which is from Ghana. So how can digital resources support antimicrobial stewardship? They should be considered as well. Around some of the international international initiatives that there are, there's the global PPS. So in the UK, we participate in our own national PPS, but we also participate in the European level point prevalence survey. So actually there is a global PPS which mirrors the European PPS in some ways, but it's expanded for low middle income settings. So actually we are encouraging that hospitals participate in this as part of these projects. But actually as part of the sustainability, for example, which I'll come up to later, can you encourage the hospitals nearby, or can you work with the teams that you've worked directly with to influence the other hospitals around them? Importance of behavioral approach as well, I've mentioned. So sustainability and scale up. So it's about enhancing the system's capacity. When we spoke to the pharmacists in the countries, they very much see this, that AMS is, yes, it's a particular topic area, but actually they do see it very much as expanding the clinical pharmacy role in the countries. And this is really key, that, you know, whilst this is focused on antimicrobial resistance and stewardship, but it gives us an opportunity to also influence and support building capacity around clinical pharmacy in these countries. We talked about in-country training. That is really essential, that it's the workforce that you go to are trained, but that you support them in what training is required, and that you should consider the WHO competency frameworks. As part of sustainability and scale up, consider professional bodies, so the medical association, pharmaceutical associations, and also the nursing association. How can you involve them or ensure that they are aware of the project? And we can do some of this once the projects are assigned and we know what countries they are. We can certainly support that, but part of sustaining and scale up could be through these national bodies. Again, focusing on tools to support clinical implementation of guidelines that are already available. As we said, you know, we would really development of new guidelines is not a focus around this, because we feel that there are sufficient guidelines, but it's how they are implemented. And how do you inform best practice? And it's important that the guidelines that are chosen are through WHO guidelines. We don't necessarily think that UK guidelines will be automatically relevant in these countries. So it's important that there is clear understanding there. And important to gather data, so baseline data collection. We will provide the tools for some of those, but actually what data can you collect beforehand? The surveillance of antimicrobial use is really key. It's important that we collect evidence. I've highlighted that we're seeing this as potential pilots that could be scaled up by the national by the departments of health in these countries, so that it's part of implementing their national action plans. Assess behavioural drivers, monitoring and evaluation, and Richard would touch on that in his section, in his talk. So we really want to build health workforce capacity. It's important that we collect evidence and monitor antimicrobial use, and that it is measurable. So actually, if there is no stewardship program, for example, could you help them set one up? And how do you make sure that that continues after this project is over? Consider what training is required and what tools to overcome behavioural barriers to inappropriate prescribing. So I'm going to hand over now to Hayley. Hayley, if you want to unmute yourself, or if colleagues at TED can please unmute Hayley.
No, I'm sorted. Hello, I'm here.
Hello, right. And Hayley will talk through what she did in the Caribbean.
Thanks, Diane, and thanks again to everyone involved in the project for inviting me to have a quick chat to you today. I've been to a couple of these launch events and shared a bit of the experience that I had working in the Caribbean over the last couple of years. So this was not, as Diane pointed out at the beginning, this was not a THET or CPA funded project. This was funded by the American Center for Diseases Control. So this is an entirely separate piece of work, but it was involved me working in the Caribbean and making several trips out there, which sounds very lovely and idyllic, but as you may well know, there's an awful lot of inequality in the Caribbean. So there was a distinct development need for antimicrobial stewardship activities out there as part of that. And so the project that I was involved with was run by the Caribbean Public Health Agency, CARPHA, who had a grant to improve antimicrobial stewardship across the 27 countries or so of the Caribbean. And there were two arms to this project. So there was one arm which was improving surveillance infrastructure for antimicrobial resistance. So in the central CARPHA labs, they had lots of kit and invested in sensitivity testing and organism identification. And so part of the project was to increase the number of specimens coming in from each of the countries, because very often there wasn't the local infrastructure to do any sensitivity testing, or, well, there was some testing, but not necessarily the surveillance locally. And so this was a central project, and that was one arm of the project. The other arm involved training pharmacists from each of these countries, and these were pharmacists from hospitals but also from primary care clinics, and they were nominated by their countries to come to the first course, for instance, was in Trinidad, so fairly central for some of the islands in that region. Another one was in Antigua, another one was in St. Lucia, and one in Jamaica. And we ran 4 basic courses, taking pharmacists from across the Caribbean and giving them a couple of days of basic microbiology, ID, and antimicrobial stewardship training. Those pharmacists then were invited to set up a local project and to run a point prevalence survey locally. So going and looking at every antibiotic prescribed in their institution over a set period of time and looking how it fitted with their local guidelines if they had any. But also, they also had a project which they brought the ideas for. So this wasn't us imposing what they should do, but it was them looking at a local problem. And they went away and worked on that and made some multidisciplinary contacts in their own organisation if they hadn't already. And those projects were resubmitted back to CARFA, and where the students or delegates had been successful and managed to get a little nice piece of work done, they were invited back for an advanced course. So they came back on another occasion. We ran 2 advanced courses, teaching them some more in-depth antimicrobial stewardship and things like behavioural techniques. And we ran things like role-playing workshops to give them some skills around challenging conversations and talking to doctors around prescribing, because as Diane pointed out, in a lot of places clinical pharmacy doesn't necessarily exist. I likened it to the way it was in the UK probably about 20-25 years ago, where you might have a couple of hospital pharmacists working in a hospital unit, but one of them would be nominated the clinical pharmacist and might make a few phone calls about prescriptions. Whereas these days in the UK, we've moved to a situation where we have maybe 30, 40, 50 pharmacists working in a hospital, and they all look after particular specialties or wards and review their patients every day and provide a very high level clinical advice, and in a lot of cases do prescribing. So as Diane pointed out, there isn't necessarily that clinical pharmacy infrastructure in a lot of places, and so it was a little bit about equipping these pharmacists to go out and teach and share and influence behaviour. And we've also, since that second course, there's been a network set up on WhatsApp, for instance, and my phone is continually buzzing because they're continually talking to each other and involving me in discussions, which is lovely. But also the hospitals, I think we had maybe 2/3 of them participated in a point prevalence study. And also some clinics did that as well. They did some prevalence work. And also we did some objective measures or semi-objective measures of how well their knowledge progressed before and after the courses. And it's just been a really worthwhile project. I had not worked internationally, not in this way anyway, previously. And it really was a learning experience for me. I learned an awful lot about how to do things differently, and I would strongly suggest, and I know there's a question come up which colleagues at TET might like to comment on about site visits. I would strongly suggest that people do build site visits into your programme, because I had no real concept of what hospitals or hospital pharmacy would look like in, say, Trinidad before I went to the hospitals and saw that they have challenges beyond anything that I've seen in UK practice. So the ceiling may have fallen down in 1/4 of the ward, but you can't close the ward, you have to carry on using it. So it's they may or may not have computer access. There were no computerized records in most of the institutions I was working with. However, conversely, there's a lot of mobile use, as Diana's already mentioned. Actually, it's sometimes you think that might be a different way of doing things. But I think from my point of view, it's a really exciting thing to do and worthwhile thing for NHS pharmacists to do. And I would certainly encourage people to consider doing it, even if it's something way outside of your comfort zone and it's something you've never done before. I think there is something to be said for going and problem solving and understanding a wider AMR context around. We know we live in a globalized society, and bugs are no respecters of country borders. They move very easily. You can be on the other side of the world in 8 to 9 hours on a plane, and so can bugs. And so I think it's very worthwhile from a contextual point of view, but I do think NHS staff will come back with a different set of skills. Now, I'm really sorry, but I do have to leave this webinar at 11. So again, I would just say I'm very happy to get in touch with anybody who wants to discuss further, but do submit your questions via CPA and THET, and then I'll do my best to get back to you.
Thank you so much, Hayley. And I think I can take very quickly now the site visit, which you mentioned. So yes, we do recommend that there's a site visit. Not every member of the project will be able to go on the site visit, but what we do ask for is that it's the multidisciplinary team that goes. So we don't, what would be the ideal will be a medic, a pharmacist and a nurse. And what's really key though, is that we show and we model how we work in the UK together. We show the best practice of working together, and really ideally to show that the that the hierarchical way of working is not as obvious in the UK, and that we work together as colleagues, because in some of these countries, there really is a huge hierarchy, and pharmacists and nurses may not have anywhere as much of a say as we do, and influence and lead in the UK. But where multidisciplinary teams have gone out, they have really, and I think that happened with your project as well, Hayley.
Yeah, it did, and I would absolutely second that. I was working with a consultant microbiologist called Dr. Richard Brindle, who's worked extensively in the UK and overseas, most recently in Bristol and Portsmouth in the UK. But we specifically built in sessions that showed Richard and I discussing cases and role modelling and showing how the discussion might go. But also, I think we both taught on all of the courses together, and the fact that there was no hierarchy there, I think in itself was a useful thing.
Yeah, thank you. And so one of the ways is because it's the organisation who is going to own the project and be responsible for the project. It doesn't have to be the same team that goes out. Ideal would be that there will be 2 visits towards the beginning and at the end. But even when you go at the beginning, there will be no time to go out just to scope and then come back and build tools. People will need to go ready to finalise their scoping, so that you can really see the context. And as Hayley said, there will be some of it you can imagine, some of them you won't be able to imagine. But even then, you may imagine the worst case scenario and get there and see actually it's not as bad as you imagine. So it's important that we don't go there with preconceived ideas, really go there to see. But what I'm trying to say is that when people go for the first visit, they will almost need to finalize their scoping and deliver implementation in that visit. And that's what happened with yours as well, Hayley, isn't it?
Yeah, sorry, I was muted, but yes. So as typically, we would go visiting on a Monday and then teach for the rest of the week. So, but yes, it did definitely change the frame in which I delivered some of the teaching, because inevitably it will. But as you say, it's a real mixed experience. So some things were worse than I had imagined, and some things were much easier. For instance, there's incredibly tight control of antibiotic supply in some of these hospitals. And only 3 days supplied at a time, and everything is documented to the nth degree. It's not on a computer, but it's completely documented and traceable. Yeah, so and that's better than I have. So.
Well, thanks to what one of the organisations we spoke to as part of our scoping said, the record keeping in this country that they worked in was much better than the UK, and it was all paper based, but much better than.
Yeah.
So, cool. Thank you very much, Hayley. I know you have to go, so
thank you
so much. Really appreciate that. We'll take questions at the end of my session, but I don't think there's any of those specific to Hayley for now. But again, we'll pick those up as we go along. So what technical support can you expect? And just before I go to that, we hope that we've been as helpful as we can as part of the call documents. I know I've spied a question which talks about there's so many elements to this, and Richard would touch on that in his session, that actually you don't have to deliver everything if you are applying for the new partnership grants. But if you're applying for the bigger grants, then it almost needs to be considered as an exception why some parts are not covered. But when you go through the documents, you will actually see that a lot of the elements are very linked. But what we've just done is to try and spell it out as much as we can. Okay, so what technical support can you expect? So as part of your planning your project, some scoping will have been done already. We would expect that to be done as part of pulling together the project. And it's important to have clear aims and objectives. And again, Richard will go into this. And there's nothing wrong with having a tight project. So by that, we mean which has a very specific core aims and objectives. But we'll be able to provide tools to assist in baseline data gathering. Behavioral frameworks, I've touched on that briefly. There will be support from behavioral psychologists as well for specific projects. Again, Richard will talk on that. We can provide links to organizations on the ground. Certainly we can provide links to the national pharmacy organizations, and we can provide links to the medical and nursing as well through our Commonwealth counterparts. So there's a Commonwealth Medical Association as well. And we'll have resource toolkits that people can consider. We're not developing anything new at the moment, but what we'll do is to signpost what we think could be useful. There will be training sessions and workshops, and again, Richard will talk on that. And it is expected that those who are awarded grants come to these training sessions, and that's where we'll really go into the details of what resources are available, what tools, and really provide more support for those projects. One of them, for example, is the global PPS as an example. So we've been working with the team on how they can support those who will be support the implementation of these across the various countries. Throughout the project, there will be monitoring and evaluation support as well. So TEF will provide this as well. There will be but this will be a joint support and technical support available through TEF CPA as well. We will provide more training sessions via webinars as we think that they're required. So for example, in the next week or so, we have sought support from the Royal Pharmaceutical Society on how do people pull together project proposals. And we've done that to go to the not next week, to give people opportunity to consider the call, to start drafting ideas and pulling things together, so that by the time we get to that workshop, actually, that you can make better use of the time and the Q&A and during the session. There is access to expert assistance by email, both through the TEF email address or the CPA email address. So why should you get involved? I think Hayley has done a much better job at this already, but what people, we know, and we've seen this happen through partnerships, and we believe will also happen through this, is that those who participate, either those who go out or those who are part of the project development. So as I said, not every member of the team needs to go out on a site visit, but actually just being part of the development of the project and talking through the project will be useful, and it will help people to develop innovative solutions to overcoming barriers around stewardship. It will improve leadership capacity within the UK, but also abroad. It will help improve knowledge and understanding of using digital technology, building greater understanding and experience of working with limited budgets and frugal innovation. I think one of the key things that people will learn, I really strongly believe, is how blessed we are in the UK and the health system that we have. And that sometimes when we complain about certain things, that there are places where obviously it's not perfect, but also there are our colleagues in other countries are having to deal with much more difficult situations. And they are working through it, and they are still supporting their patients and really focusing on patient safety as well. It will help expand non-clinical skills such as project management and some finance as well, management. And it will expand understanding of antimicrobial stewardship in a global health context. There'll be opportunities for professional development and research skills as well. And for those pharmacists who are part of the project, we are working with the Chief Pharmaceutical Officer to consider a fellowship support, so that those who participate or complete certain parts of the project are awarded a fellowship title. We are just working through that at the moment, but that's one support through the pharmacy route. But it really is trying to build those skills in. So I will now go and try and work through the questions that we have. But if you've got any specific questions for CPA or any specific antimicrobial stewardship questions, please direct them to amr@commonwealthpharmacy.org. If you have any questions about the grant itself, then this one needs to go via TEF, but Richard will go into further details shortly. So I'm going to now just try to work through the questions that have come through whilst I've been talking. And the first one I can see is having an NHS partner mandatory? Could there be pharmacology, pharmaceutical expertise from the HEI sector? Because organizations will be working with hospitals in the partner country, we do an NHS part. If the lead organisation is not an NHS organisation, there will need to be an NHS organisation as part of the project or partners. Richard, did you want to say any more on that?
Oh, I think that's fine. They can be one of the additional partners in the application form, but you need to clearly explain how they will link into the project and how volunteers from the NHS will get involved and the benefits back to that institution.
And in terms of the team that go out, they need to be clinical team that go out to the countries to support them. But certainly, as I said, in terms of the expertise that is part of the project team, that can be a wide range of individuals, so including pharmaceutical expertise within HEI sector. But again, when we are going to talk to our clinical colleagues in other countries, we would want it to be clinical colleagues from the UK as well. I'm not sure when Malawi has been highlighted on a map, so Richard,
sorry, that if it is, then I'm sorry, it shouldn't be. It is the 4 countries of Ghana,
so the 4 countries
and Zambia.
Thank you. So there's a question from Roger, says, Diane, when you say multidisciplinary team is essential, do you envisage a multidisciplinary team? Yes. So we ideally would want to see the 3 professions, but we know that this may not be possible. But I think that people should be able to at least have a doctor, a nurse and a pharmacist go out, and they don't have to be from the same NHS organisation, but it's about those clinical teams showing that multidisciplinary working when they get to right, so another question says, the project seems to need many various strands, and for the amount available, is it realistic for all these to be met? I just envisage how many people and how many times you expect to visit. So Richard, did you want to take the question around the amount? I think that's really around the 75,000 and the lower amounts and what we expect them to cover.
Yeah, sure. So, so for new partnerships who can bid for up to £30,000, we really are just asking for applicants to cover just a few of the scoping study requirements. So we don't expect you to go through all of them. We'd like you to pick out a few and explain what you'll do with them, and then put some reasoning in for prioritising those over the other scoping requirements. But as we said, for the partnerships the established partnerships that can get funding up to £75,000, we have suggested the scope that the applicants cover all of the scope and study requirements. If, however, it's not quite applicable for this particular project, then there is space in the application form to explain why. So do please just provide full justification for that.
And we've made things easy by providing a checklist at the end of the full document to just help people think through the various aspects. Okay. Is the budget inclusive of UK partnership support to local countries? I think that's so. Richard, did you want to take I'm reading this as, will there be budget for the local countries?
Yeah, sorry, I can't see the question.
So the question says, is the budget inclusive of UK partnership support to local countries? So I'm interpreting that as, will there be funding? So UK partners obviously are the ones who are responsible for the budget, but is there going to be funding provided to the other countries, to partners in the other countries?
Yeah, so partnerships are very welcome to develop the budget how they would like, but we're very happy to receive applications which include funding for the overseas institutions, whether that's within project management or monitoring evaluation categories or elsewhere. Partnerships in the past have done it both ways. Sometimes most of the money has stayed within the UK institution, other times it's split more 50-50. So it depends on the nature of your project, but we're happy to see funds spent within all institutions. And
I think it'll be encouraged as well, because it depends on the tasks that is required, and so that's why it's really what we've specified is that the project plan should be co-developed. And I guess it's really about what tasks or what activities will be completed. So if, for example, you're going to train, the UK organisation will not be training in the UK, they'll be training in another country. So if there needs to be a room booked, for example, then that will need to be done via the country rather than within the UK. So hopefully that helps explain that. Kindly draw more light on overseas partner institutions. Okay, I'm going to try and interpret this as well. So what the core elements of the partners is around hospitals in the UK and hospitals in the countries, in the 4 countries. But the other partners can be regulatory organizations, professional associations, education institutions. And that can be from both sides. We do need to see that the pharmacy element is central to it on both sides in both countries, so UK and the partner country. Richard, did you want to try and add more to that from the limited question we've got?
No, not for now, but I'd encourage, I think it was Ronald who asked it, if you just email ams@thet.org, and presumably you have some specific organisations in mind, and we can get back to you more specifically on that.
So this question here is UK HEI FEC allowed? So I'm assuming it's UK Health Higher Education Institutions. I can't remember what FEC stands for, but UK Health Education Institutions can be a partner. Richard, did you want to take that further?
Yeah, I was desperately trying to Google FEC, but I'm not quite sure. Sorry.
I think is anyone full economic costs? No, but anyways, Richard, I'll let you explain that. So it's basically the overheads to universities.
Yeah, so the way we set the budget up, thanks Roger for clarifying, the way we set the budget up is that people can put in costs for project management and monitoring and evaluation. Often that will be some staff time and potentially some contribution to office costs, but it's not, there's no line and there's no allowance for the official university overheads that I know that universities have to cover generally in their grants. So we're picking out the specific time and cost to deliver the project management aspect of that.
Thank you.
We've had several universities who have had health partnerships in the past, and they've managed to work a way around this to be eligible for set funding and also to fit in with their university requirements. So if you would like to be put in touch with other people who have developed budgets for universities, then do let me know, and I can see if some of our contacts can help you with that.
Excellent, thank you. I think those were all the questions from my session. I'm going to hand over to you now, Richard.
Great, thanks very much, Diane. So this is the last section of the webinar, so thanks very much for sticking with us. Our role at THET is often to link the world of the health worker sector with the world of international development, and we realise that some people aren't, or many people aren't familiar with international development project management and putting together project plans. For those who are, this might be a bit familiar with you, so apologies for that, but I'm just going to go through the basics of project planning for you now over the next 15 minutes or so. So it's that we see there are 4 ways to think about developing your project plan. And I've listed them here. So what is the problem or needs that you are trying to address? What change do you want to bring about to address this need? What do you need to do to ensure these changes will be brought about? And how will you know if you've been successful in doing so? And I'll just go through each one. So to start with the need. So in your application form, I think in section 3, we've got a few questions that we're allowing you to draw out the needs that you've assessed in the country within which you'll be working. we'd like you to look at how you've identified the needs. So we really want you to go into detail about what methodology you used, who was involved in this needs assessment. Did you speak to the health workers? Did you speak to management? Have you spoken to national and regional government officials? Did you speak to beneficiaries or service users? Not necessarily saying you need to speak to all of these, but do just think through who the right people to speak to are. Please do consider which other stakeholders are already working in this area to address issues around AMS, and if so, does your plan potentially duplicate what they're doing, or does it complement? If it complements, that's absolutely great, and that's one of the purposes of this scheme. But do draw that information out in the application form, make it very clear to us how your project dovetails with others that are potentially going on. And then do consider how this problem affects different groups and potentially marginalised groups. So we've asked for just a couple of sentences reflecting on access to either the training or access to these services that you're improving for marginalised groups, such as, or often overlooked groups such as women and girls, people with disabilities, etc. We're not asking for much more than that, but just evidence that you've reflected on this. So I've started to develop a little example of what is called a theory of change. It's a very simple theory of change, but when you're mapping out your plan, you begin with the problem. So for example, you've identified in your institution that patients aren't being prescribed medicines correctly and healthcare workers do not know how to use antimicrobials appropriately. If we move on to the change that you want to bring about to address this need, and I've just listed the 3 outcomes again that we're asking projects to input into. But let's say the change that you want to see at the end of this project is at least 75 staff reporting or demonstrating improved antimicrobial prescribing practices following training. And in section 4.1 of the application form, we've asked you to list your changes. So I think for new partnerships, they need to list up to 3 changes, and for established partnerships, they'll need to list up to 4 changes that they hope to see by the end of the project. And I do ask that you're as specific as possible. Basically, go down the SMART route. Please just give us a specific amount of information as you possibly can at this stage, so that we can identify from the application form exactly what you're hoping to achieve. What do you need to do to ensure these changes will be brought about? So as we start to gather together this theory of change, we're going from the problem to the end goal, or the final change, or the outcome as it's also known. There's lots of changes between the problem and the final change that you need to think about to be able to reach your end goal. And in international development terms, that's sometimes known as outputs or short-term change. So for example, in this very brief theory of change, you want to get to 75 staff having improved practices, and therefore you'll need to carry out a training in order to improve their practice. But there's a big leap between carrying out the training and them actually practicing better. So your short-term change to see if the training's actually worked is for 100 staff, say, to have appropriate knowledge of antimicrobial prescribing standards. So this is immediately after training. What is the change that you've seen? And it's increased knowledge of the trainees. That doesn't necessarily lead directly to improved behaviour. So as you're developing your plan, hopefully, if you want to use this kind of model, you'll have a lot of short-term changes that will build up, and that will eventually lead to your final outcome. And in section 4.3, we've asked you to list all the activities that relate to those short-term changes that I've been speaking about. So this is just an example here of some activities you might do. There's a lot of information in the FAQ document online with more ideas about what kind of activities would be useful for this program. Now, as you're thinking about these changes, naturally you'll also start thinking about what elements could prevent you from achieving those changes, and particularly if there are any external factors that are required to happen for your final changes to occur. So within this short time frame and within the limited budgets that you have, we need you to not be too ambitious. If there are anything that needs to happen externally, say a national guideline or policy needs to be put in place for you to achieve your goals, then unless it's very likely to happen, we won't be able to accept that as an application, because you need to be in complete control of the changes that you're hoping to achieve. And so these are known as assumptions and risks. So do think carefully about what needs to be in place for your activities to lead to the changes you have identified. Do you think about what barriers to change exist and how your project will overcome these? There's a section in the application form to list these out. And do you think about what risks the project might face and how these can be mitigated? And then finally, how will you know if you've been successful at bringing about these changes or monitoring and evaluation? So we'd like you to consider what data will you need, who will collect it, when and how. So is this going to be the in-country institution or the UK team or both? How will you analyse it? How will you monitor any unexpected outcomes? And will you have a research element to this project, which is perfectly fine, and we're happy to consider those, but do make sure that's explained in the application form. So I've just got a couple of tools to show you which are available on our website, www.thep.org, and in the resources section on there. We're not asking you to submit these as an application, but we probably will be using tools similar to these once grants have been selected. We'll work with you to develop these plans more fully. So this tool is just for you to use during the selection process if you would like to. You don't have to. It's just there for your support should you wish. So this is a project plan, and it just goes into a bit more detail about the changes that you hope to achieve. So on the left-hand side, you have the objectives, and we have the outcomes or the long-term change that you'd hope to see. And so I've used the same example as we had previously. And then you would have several outcomes, up to 4, as I said. And then below that, you have your outputs. And often your outputs, so output 1 would link directly into outcome 1. So output 1 is the short-term change, which links directly into outcome 1, the long-term change. And then, yeah, the plan just allows you to put a bit more detail, a bit more flesh on the bone. So it encourages you to think about how you know this has been achieved. So in order to determine whether antimicrobial prescribing practices have reached an agreed benchmark, you need to see how many staff are demonstrating appropriate practices, let's say 3 months after training. So not immediately, let's wait for some attrition of knowledge and see if 3 months after training behaviours have actually improved. It suggests what the target number might be. Encourage you to think about how you'll get the evidence for this achievement. So who's going to monitor this improved practice? And then the assumptions column is where you try to draw out any external factors to your project. So in this example, the assumption for outcome 1 is trained staff have a ready supply of the correct medicines. And the assumptions are really what is the goes between the output and the outcome. So following your outputs, you have 100 staff who have improved knowledge. But what is going to get in the way of reaching outcome 1, your final change? And so in this example, staff have the knowledge, but what if they don't have a ready supply of the correct medicines to actually use in their practice? And therefore, can you actually say that staff are demonstrating appropriate practices? And so these assumptions will just help you think through other activities that you might wish to include in your project in order to reach your long-term changes or outcomes. Another plan that's a bit more detailed is the monitoring evaluation plan, again, that you may wish to use. And this looks into more detail into how you will collect and analyze your data. So this whole page is just focusing on output 1 in the top right of the screen. So number of staff, demonstrating improved knowledge, immediately after training, and it makes you think about how you're going to determine that this has actually happened. So just to quickly run down the rows, you may wish to think about how the data is going to be broken down. For example, it could be broken into gender, cadre, and disability. We're not necessarily suggesting you should do that. This is just something you might like to think about doing. The data collection section asks how often and when will the data be collected? How will the data be collected? What tools do you need for data collection? And who will gather the data and create the tools? And I've just put some examples on the right-hand side. And what's really important underlining all this is that we do ask that partnerships work jointly on this as much as possible. So often one partner will take the lead in a certain aspect of the project, but we do ask that it's not just the UK partner doing this work, or it's not just the, say, Ugandan partner doing all this work. It should be jointly run. And then going on to data analysis, similar questions, but what tools will you need for data analysis? When is it needed? And who will do the analysis? And hopefully using something like this will help you consider what is actually achievable within the short time frame of 15 months. So those tools can be found on our website. What can also be found on our website is our principles of partnership. As Will has referenced earlier, the principles of partnership are a set of 8 principles that FET has developed for over using our 7 to 8 years of experience in the Health Partnership Scheme and feedback from all the partnerships we've worked with and our own learning. So these eight principles are a kind of standard for health partnerships to reach. And behind each principle, there's a series of hallmarks. So if I just bring out one example. So for example, in the strategic principle in the top right, one of the hallmarks would be partnerships have a memorandum of understanding which they abide by and put into practice and regularly review and update. We are asking that established health partnerships have a commitment towards these 8 principles, and that new partnerships have an adherence to these 8 principles. There's a lot more information on the website. I'm not suggesting that applicants should read through every single page on it, but maybe it'll be useful to just find the landing page and familiarize yourselves with some of these principles. And if there is something that you suddenly click and you think, oh, we don't have much in the way of flexible, resourceful and innovative behaviours as part of our partnership, then maybe that's something you could address over the next 2 months. Also within the website, there are tools and case studies attached to each principle to help partners think about how they could improve on these standards. As I said, there are heaps of resources on our website. Do please go and check these out, particularly for new partnerships. There's everything from how to set up a new partnership, how to plan your project, how to do monitoring evaluation, how to run a needs assessment, how to use medical equipment, and these are all focused on global health partnerships. So I do really encourage you to check these out, especially if you're having particular issues with your application form. Do please have a look. And yes, thank you. That's the end of my set of slides on project planning. I've got a bit more to speak about in terms of behaviour change, but I'll just pause there and see if there are any questions that have come through. I can't see any questions for now, so I'll carry on, but we'll have time for questions at the end, should people wish. So we touched on behavioural change a few times already. We are in partnership with the Manchester Implementation Science Collaboration, which is run by Joe Hart and Lucy Byrne-Davis. They are health psychologists based in Manchester, and they've worked with that on several health partnerships in the past in improving behaviour change in our projects. So in essence, what they do is take a look at the training, the resources and the implementation of improved services, and really try and energize that and ensure that it's sustained following the training. And here's, Diane's already spoken to the model, but just to outline it in brief, behavioural change helps partnerships with three things. So understanding the barriers and facilitators of starting new practices or stopping old practices. It looks at developing interventions or training which addresses not just capability but also opportunity and motivation. And it looks at evaluating not just whether interventions work, but how, why, and how they can be enhanced to make practice change more likely and more sustained. Now, the way that Joe and Lucy will get involved will be following the selection process. So it's nothing for partnerships to be concerned about during the application stage. But once grants have been selected, we will be running a 3-day workshop for all partnerships for those partners based in the UK in February. And part of this workshop will be guidance from Joe and Lucy on how to improve your training and your activities to ensure behaviour change is actually achieved in your institutions on a long-term basis. So that's partly how they'll be involved in the programme. The other side is that we will give 4 partnerships the opportunity to invite health psychologist volunteers to join them in their project to go to the institutions in the low-income countries and really try and embed behaviour change there. So they would spend, well, we're not sure on timings yet, but anything from 2 weeks upwards in the overseas institution to work with the partners on this. And as I say, following selection of the grants and probably following the workshop that we'll run in February, we'll work with the partners to see which projects this most makes sense for. Sometimes this particular behaviour change model won't be relevant to certain projects. And just a brief slide on how this has worked in the past. So there was a partnership between Ipswich Hospital and Beira Hospital in Mozambique, and this was part of the Health Partnerships scheme. And it welcomed 2 psychologist volunteers over the course of a couple of months who developed behavioural science inputs. And I won't go through this, but just as a site here, just to show the kind of work they were doing and how they got involved. But we have seen over the last few years that it does make an incredible difference to these projects. And just a quote here from Sarah, who was the lead for this project, on the kind of input they have. So if you have any particular questions, please do get in touch with Joe or Lucy about that. As I say, this won't really come on tap until February, so it's just to alert you really at this stage as to how successful partners will be helped during the programme. So that's that on behaviour change. Just the next steps for applicants then. The application deadline is midnight on the 4th of January. Please do submit the application form, the budget and the letter of support. And please do use our templates for the application form and the budget. We won't be able to accept any other template. And you can email ams@thet.org for that. In the interim, you're very welcome to email ams@thet.org for questions around eligibility. Particularly, we get a lot of questions from potential partnerships who aren't sure if an institution is eligible or not. So please do send those through. And as Diane said, please email CPA for technical eligibility questions as well. And this webinar will be going out on Monday, so do have a look back at the website, and we'll email those who have put their emails in the chat box directly. So I think we'll take a few more questions if that's okay. We've got one from Dot here to clarify who we expect letters of support to be provided by for the applications. So letters of support should come from a member of the senior management or leadership team at each institution. Ideally, it would be someone who is linked in some way to either the project or the type of work that would be carried out. But ultimately, we need some kind of institutional proof that the institution is happy to be involved in this project.
So, for example, it could be the chief pharmacist, if it's a pharmacist involved, or it could be the medical director. It really just depends on who's involved within that organization, I guess. There's a question about, is the focus on behavior change of the population or the pharmacist? It's certainly about the healthcare workers, not the patients. And if you can include patients, that would be an additional benefit, but the focus is on the healthcare workers.
Yeah.
Sorry, Richard, that's just answering that technical bit.
Yes, no, absolutely. Just see if there's any more questions coming through, but I think we've answered all of them. So as I say, please do, if you have more questions, email us at the address there on the page. Otherwise, unless any of my colleagues wish to say any final words.
Nothing from me, but is Chloe still on the line from CPA? If there's anything she may want to add.
Hi everyone, no, I nothing to add from me.
Thank you. Nothing else from me. Thank you very much.
All right, thanks both. Well, yeah, just leaves me to say thank you very much for listening, and best of luck with your application. I hope it's not too much work for you. We are really excited about this program. It's been many years in the offing, especially for people like Diane, who spent a lot of time putting this together. We really would welcome applications from new partnerships, from people who haven't been aware of the health partnership model before. Please do put an application together and send it through to us. And if you have more questions about this model, do let us know. So yes, thank you very much, and best of luck.
All the best, all. Bye.
Bye, everyone.